Professor Sherman Eisenberg for choosing this instruction course for actually delivering one of his guest lectures. When we submitted the course, we were not actually sure whether we should submit it or not. This is the first time we'll be doing imaging in babies. Bad enough. Pediatric is a very narrow field, and there's just very few instruction courses that get accepted. We're very happy. We're even more thrilled than Professor Eisenberg wanted to speak through this course. And I also want to acknowledge the presence of Professor Anand Vinekar and Professor Del Monte from Illinois and Michigan, who are here. We're very honored that you're here. We have your comments with you again this session. The idea here is just to talk about what recent advances have happened in our ability to image what so-called normal-looking babies, especially normal-looking retina, and otherwise not normal. So I'm outlining my talk into three parts. One is imaging the unseen, which helps us see better, kind of and imaging the image, which is going to be some experience we've been having with software analysis. And the third is going to be just a few cases of explaining unexplained visual loss, kind of paradox. So I think part of my talk is going to be on OCT, because I can relate with the previous session. And pediatric OCT, infant OCT has come of age now. And before, borrow those pictures from C.K. Patel and others in the United States have also shown this used to be called the flying baby position, where you had to literally take in those days, the time domain OCT to the OR and laterally or supinely the baby. But today, with modifications either of regular handhelds or the availability of the handheld OCT, we're able to image that part in the OR, in the clinic, in the office without anesthesia, things that we were not able to see. So the first thing I want to bring to your light is that we know so well this adult OCT picture. We know the layers, we know what's inner and outer retina is marked in blue and red here. But it's interesting to know that infant OCT is not the same. All of us, especially if we're born premature, don't have the OCTs of, let's say, adult in our parents. And that's something I want to bring here too. So this is the inner retina, and what happens in an immature retina is this outer plexiform layer. First of all, it's an easy thumb rule that whenever you're looking at a spectral domain OCT, the white lines are plexiform and the black lines are nuclear. So this would be the outer plexiform and this black would be the outer nuclear and so on. So this outer plexiform layer is not touching the inner retinal layer. Just go back to the other. You see, this is what we call an inner retinal migration. There are many theories of why this happens and when it happens, but it must happen. If it doesn't happen at the correct time, children tend to have poor vision. So this inner retinal immaturity is one of them. The second thing is an important layer is the external limiting membrane, the lightish gray one there. And then I'll go back to the adult again. You see this foveal tent. So this inner segment, outer segment, which is the whitemost line here, has a little bit of a hump there and a little more blackened area there. That's because of the longer cones. The cones actually have longer cilia than the fovea, the subfovea, and that's what actually pushes this up. This middle layer is often not given a name in adult OCT, or it's called the COST, or the whole outer segment terminal. However, in pediatric OCT, and a lot of this work is done at Duke University, we actually have a name of another layer which is called the OSRPE, or the outer segment RPE. So it's really in between the ISOS and the RPE. So let's look at how we can use OCT to actually map some visual changes. That's what really gets us working, how we can predict vision. So this is a premature baby born at 38 weeks. And now what you see here is just the RPE line. And what I want you to see, and I'm going to play these next few slides in rapid succession, it's going to be like a flip book. So you're going to start seeing this blue, two arrows start converging. And what that's going to show you is the inner segment, outer segment actually comes in from the out. So it's really a centripetal migration. So here it is, 38 weeks. At 42 weeks it's coming closer, but it's still not two distinct layers. At 46 weeks it's almost coming closer. Also notice that the outer plexiform layer is fusing. And then at about 47 or 48 weeks, that's what studies have shown. The average is about 48 52 weeks, that's the third corrected month of premature babies, is when you will get a double line. And then, of course, the foveal tent is something that happens even much later. Here it's at 48, it's completely fused, you see a two lines. This is serially mapped on the same baby using the same device. So we actually serendipitously discovered this when we were actually trying to map NVEs of ROP. We were also mapping obviously the foveas, and a clinically normal looking fovea, of course this eye had a stage 2 in the zone 2, and this eye had stage 1 in this example. And what we found was about 30% of stage 2 ROP babies ended up having these foveal disruptive changes. Now we did not call it cystoid macular edema, it was very tempting to do that. It resembles the adult forms. But because we simply didn't know what character these had and what pathology they carried. But what we found is we found two distinct patterns in this. So we called it pattern A and pattern B, and we characterized that. And basically in pattern A, you have a complete foveal dip disruption and these large cystic spaces. And in pattern B, you have some amount of the foveal dip preserved and cystic changes. It could be a minor version, it could be one that's seen much later. But what we noticed is both of them are self-resolving. So by the 52nd corrected week, which is the third one, they seem to completely go away. So what influence that could have on vision in long term is something that we've been studying now, and some of that is what I'm going to share with you. So what are the layers in a fovea, especially in a developing, evolving fovea, that code for vision? So the first one, this is again, we just saw this daily. In our setup, we do at the third corrected month, we start assessing their vision and their refraction for premature babies. So this is a 3-month-old baby who had 20 by 1,400. In our nomogram now, we know that's less. At 3 corrected months, they should at least be 540 or 670 on a 10 equity. That in our settings. Again, a 3-month-old baby who had a normal vision for that age. We looked at the OCT to see if it will tell us something, and you can immediately see that the inner retinal layers have not fused, but that's the star. That means the outer plexiform layer is quite far away from the inner limiting membrane, whereas here they have fused. So inner retinal fusion, we found, was a very important indicator that they would have better vision earlier. And then, of course, you see that the one, that line, this is the inner segment, outer segment, not coming to the center, but here coming beautifully to the center, a bit of the OSRP as well, and even some tint that seems to be developing. So then we did, of course, this was retrospective, and now we're just completing our prospective data. And so the plus would show you which layer was positively influencing vision, statistically at least. So we found that the inner retinal layer migration, is the same example, has better vision. And the earliest we saw this fusion was 3 months, and the oldest case in our cohort, now 18-month cohort, was 9 months when they did not have fusion and therefore poor vision. We were also able to image the external limiting membrane a little earlier than the Duke group. We used a different protocol and a different device, but we think that between 41 and 45 weeks is when the external limiting membrane should appear, and the appearance of that codes very well, positively for vision. We then found, of course, that interestingly, the inner segment, outer segment, which we are so accustomed to thinking codes for vision, especially in adult macular hole surgery, where some amount of prognostication is made just based on whether iris was present or absent before surgery. Interestingly, we found no correlation. But this is not a negative correlation. It means we did not find a statistical correlation between this layer and vision. Interestingly, we found the outer segment RPE, which is that jelly-like, a shading layer, which is now a very distinct layer in this picture. We found that to code positively for vision. And of course, the earliest we saw that happen, USRP, was 6 months, and even at 9 or 12 months, it sometimes did not happen. Then we looked at the sub-cohort of babies who had retinopathy of prematurity and looked to see if ROP is delaying some of these layers, and therefore indirectly or directly affecting vision. And we found two things. One, ROP negatively correlated with the presence of the later presence of external limiting membrane and the inner segment, outer segment layer. Now, one of them codes for vision, one of them doesn't. So now we're very keen on following these babies prospectively to find out what happens. This is the external limiting paper. So the summary of findings in terms of the OCT layers and vision was there seems to be a positive correlation with inner retinal fusion, external limiting membrane, and the OSRP. There's no correlation, interestingly, arise to us, a negative correlation with the presence of ROP. The second part of my talk is just to introduce you to some of the very interesting work we've been doing with some biomedical engineers. We're taking regular RED-CAM images and trying to non-invasively pick up information of the vascular tree. Now, of course, we can do this with an angiogram, but we're just blessed with the RED-CAM shuttle and we're not able to do that. So we're just wondering how we can pick up better vascular information. So this is of course a patent pending image processing tool that they use. It's indigenously developed. The original photo that hardly shows you where the edge of the flat neovascularization is, a color enhanced which actually shows you that, a gray enhanced, and then this is the more interesting one, which is the vesselness measure. Just let's take one example. This is zone 1 aggressive posterior ROP. It's the right eye, fovea somewhere there, and you really see that the vessels have not even reached the center of the blanket. And what we're trying to look at is by getting this kind of a vesselness protocol, are we able to detect vessels beyond where they are seen on the naked eye? And therefore, maybe we can actually recharacterize or re-diagnose these patients from zone 1 to maybe even posterior zone 2. And we all know what a huge difference that makes in terms of the management decision and the prognostication and even how they do for treatment. As we know, Flynn group has described what the difference between vasculogenesis and angiogenesis is. So we're trying to see if we can match vessel anatomy picked up this way. We look at a few more examples of the occluded venous leg in this child who was just a few months old. You can probably see it better here, these occluded vessels in the color enhanced picture as you wouldn't have seen it in the original picture, and you see a complete absence of capillaries and the dropout there in the vesselness protocol. And then this was a CRAO, a bilateral retinal artery occlusion. We saw in a 4-year-old with nephrotic syndrome. We know they are in a hypochondrial state. This was a severe retinal artery occlusion, so the child did really well. But this is not the angina picture. This is to show you that some amount of capillaries are actually there in the center of the fovea. We saw a map which was consistent with the sparing of the severe retinal artery. I'm going to conclude with 3 or 4 cases that, this is that I shared with Dr. Ashwin, cases that we've been looking at in the clinic, doing their OCTs, and then matching what we find with the electrophysiology. This is a 7-year-old female now with a refractive error, as you would agree here, it's not very big. And but the vision is much lower than what it should be. And of course, the parents are cousins, so there's a lot of consanguinity in our country, especially in the state that I come from. And 2 other siblings seem to be normal. There's an intermittent divergent squint. The fundus and color vision are normal. There's not much we know. These are co-shared patients. So if you do an OCT, from the knowledge that you know already, the inner segment, outer segment is completely eaten up here, right in the fovea. There's a presence of an external limiting membrane. The IR inclusion seems to be good. There's almost no tall cones here. So the inner retina seems to be normal, but there is a disruption and loss of fovea 10. The cone vision in the fovea seems to be depleted. So interestingly, a full field ERG was almost normal with minimally reduced and a bifid bleed with the photopic white flash. This is I'm trying to show you how some OCT findings can be subtle and actually can tell you of a tale that's otherwise going to be this. This is the macular integrity assessment of the Maya, as we call it. It works on microperimetry philosophy. You see, that's the scotoma, that's a depressed sensitivity right in the foveal center, otherwise doing well. That's like a sea of darkness, an island of darkness, a sea of otherwise good vision. But that's troubling the patient. That probably explains the 616 and 618 vision. Again, in the left eye, that central scotoma. So we go on into a multifocal ERG, this is what Ashwin did, and of course it shows a central reduced response between the first 5 degrees with the reduced light T. So again, probably early cone dystrophy. I'm just trying to show you the synergy between OCT and other tests that we routinely do. Again, this is the right eye of a patient, 6x6, that's the refractive error, and you can see this is a very healthy, normal OCT, a 7-year-old who's been labeled anisometropic amblyopia. That's the difference, may or may not be, not improving with patching, although compliance has been measured. You see, this OCT intuitively tells you that there's something hugely wrong. You see a not compacted inner segment, outer segment. You see these 2 really far off layers. You don't even know whether this is ISOS or this is ELM, or these are just ISOS that's more skipping. But the point is that structure is defining some of the abnormal function that you see. You see the outer plexiform layer is not regular here, it's not fused, and the outer nuclear layer almost seems to not be there. So let's look at that left eye a little more deeply. So the marked attenuation of the photoreceptor complex, the ISO is much thinner, wider separation, the outer plexiform is irregular, and an inner retinal anatomy is not even developed. Again, a full field ERG is normal and cannot contribute to our understanding of this case. So again, could this be a candidate for multifocal ERG, or is it just poor compliance and patching, or is it something else? These are more questions than answers really. My third case is a 9-year-old, again not improving with patches. There's a bit of a cylinder here, and almost the same here, 615 and 618. You see again, this this ISOS is so much thicker, abnormal, irregular, patchy, and the external limiting is a little far away and the outer nucleus is also spaced out. You see these almost nodular-like lesions here. I mean, they're not really lesions, but is this just clumping of the cones, the photoreceptor layer? What do these mean? How do they offend us? Is this just ischemic insults that happen much earlier and is that why they clump? Is it anything? I mean, these are just questions, but just to tell you, to open the eyes that, otherwise, the anatomy looks normal, the fundus looks completely normal, the full filial again is normal. My fourth case is a case where it's again a 6-year-old not including fracture and with glasses. Again, compliance is measured. What you see here is the outer nuclear is completely thinned out. You almost see no black layer in the center of the fovea. The ISOS is broken. There's an external limiting membrane. There's almost nothing there. You would think that this could be something like a solar retinopathy. The outer retinal folds, the outer retinal changes that you get. And again, the same changes are almost similar, with similar vision in the fellow eye as well. The ERG report, interestingly, has some abnormality here. It says it's a supernormal scotopic response. The cones are definitely subnormal, and Ashwin recommended that we do a multifocal ERG on this patient. So really, to summarize, the spectral domain OCT, especially the bedside one, has a clear advantage in helping us better understand and do a better subclinical assessment of these children. Certainly helps us understand the disease process, the natural history better, and maybe soon with some of the layers prognosticating for some vision and some not, we would have a sort of roadmap to figure out how we can predict vision better in a partial vision. A lot of these images are in the spectral domain OCT text that we brought out. We had several national and international contributors. Thank you very much for being here.